time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Whip game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we when we link up. Let's go. Yeah, I got the
Welcome to Kidney Hub East Africa Frontline Voices. I am half your host, Steve the Kidney Nurse. Today, we're joined by Tabitha Matekwa, a dialysis nurse in Nairobi, to talk patient care, challenges in the clinic, and hopes, and what hope looks like for people with kidney disease across Kenya. So how's everyone doing? It's been about, a week? And I hope everyone is doing well wherever you're watching from. So let me introduce my co-host all the way from Kisumu, Kenya, Moses Kidney, also known as the Kidney Ambassador. Brother Moses, welcome.
Thank you so much. What amazing show today. We expect a lot today, and I'm super excited as we invite Nurse Tabitha Matekwa. Thank you so much. Back to you, Steve.
Yeah, hey, Brother Moses, I'm glad you were able to get in contact with Nurse Tabitha. She's been a supporter of this show. She also been a supporter of my platform, Steve the Kidney Nurse. And this has been an interview a long time coming. So let me just share some slides of Miss Tabitha, who is a renal nurse specialist and also an advocate. Now, let me share some pictures. Here we have Miss Tabitha at an event, uh, promoting kidney disease awareness. We also have her here wearing the Baxter shirt for Kidney Awareness Day. World Kidney Day. Tabitha is also a mother, and she shares some pictures of her with her family. Again, advocating for kidney disease in Kenya, and then also with the group Kidney organization that raises kidney awareness across Kenya. So without further ado, let's bring on our special guest, Tabitha Matekwa, all the way from Nairobi, Kenya.
Thank you. My name is Tabitha Matekwa. I am also.
Hi, Tabitha. Welcome.
Oh.
Welcome, Tabitha. Can you hear me? Hi, Tabitha. Can you hear me?
Thank you. Yeah. My name.
How are you doing?
Tabitha. Thank you. Yes.
So how are you doing, Tabitha?
Yes, I can hear you.
All right. How are you doing?
I'm doing fine.
Good. So Tabitha,
I'm doing very fine.
Can you introduce yourself, where you work, and your role, and how long you've been a dialysis nurse?
I am doing very fine. I've just been at home over the weekend. Yes.
So Tabitha, where do you work? Introduce yourself. Share your story with the audience.
Thank you. My name is Tabitha Matekwa. I work in Kenyatta National Hospital. It's actually the I'm Tabitha Matekwa. I work in Kenyatta National Hospital. I am a nurse, a nephrology nurse. I've been working in our renal unit since 2005. That is close to 21 years. Then for the last 7 years, I've been supporting kidney patients, doing counseling for them for the last 7 years. Yeah.
Thank you for sharing that. Let me
ask you,
Tabitha, what drew you to work in dialysis?
So I've been working in the dialysis department. Yes.
What drew
Taking
you?
care of renal patients. I counsel them when they're starting dialysis, on their journey towards transplantation. I take care of caregivers.
Okay. So Tabitha, let me ask you. Let me ask you a question. What drew you to work in dialysis?
I just saw an advertisement and I wanted to upgrade because I just done basic nursing when I saw the advertisement, I said, I need, yes,
So can you repeat that? What brought you into dialysis?
yes.
Can you repeat what you said?
Upgrading my education, and I just loved the kidney patients, taking care of them. The most interesting thing is that when you take care of them very well, they do well, and you're able to let them have longer life. Yeah.
Okay, okay. So Tabitha, can you tell us what a
What really brought me into dialysis? It was the reason I fell in love with the kidney patient and taking care of them. Once you take care of them very well, they do better, and you are able to increase their quality of life. Like you can see our kidney. Repeat. Sorry, kindly repeat.
Yeah. When I asked, can you walk us through a typical day shift in the dialysis unit? Can you tell us what that looks like, a day in the dialysis unit?
Is it the network coming? Hi.
So Tabitha, can you hear me? Okay. Can you tell us?
A day in the dialysis unit. As a nurse, you receive the report. Yes, I can hear you. Can you hear me?
Yes.
You can hear me?
Yes.
Yes.
Yeah.
So take us through a typical day at the dialysis unit. Brother Moses, I know we have internet issues over in Kenya. So when she comes back, can you ask Tabitha to take us through a typical day that she goes through at a dialysis unit? From your standpoint, Brother Moses, what does a typical day looks like for you in the dialysis? Okay, we got Tabitha back. Hold on.
All right.
Wait a minute. Well, I want us to tell her to walk us through a typical day in the dialysis unit from her standpoint. Okay. Okay, Tabitha, we got you back. Can you hear us? Brother Moses is okay.
Yes.
Tabitha,
can you hear us?
Turning off my.
Is there enough network now? You can move closer to your router.
Yeah, the network is back now.
All right, yes. Thank you. So Steve wanted to know the typical how the typical shift in a dialysis looks like.
Just because
maybe you can take us through how that typical day shift in your dialysis unit looks like. You get it?
Mm-hmm.
Yeah. Kindly take us through.
As I was saying as a nurse.
Yes. Check on your microphone.
Yes, you receive the report of the patient.
Brother Moses, it looks like she's having some issues with with her internet.
Yeah, I guess so.
So, Brother
Maybe.
Moses, can you take us through, from your perspective, what a typical day shift looks like from your perspective in Kenya?
Well, thank you so much. This comes as a routine to me to save my life as a patient, and it happens twice a week. And my sessions normally begins around 6:30. So my treatment begins at 6:30, and it is also sometimes guided by moods and feelings, because the first thing you walk in a dialysis unit, and there is a nurse who perceive you not to be kind, or just you doesn't get along. But then treatment being a thing that looks more of a family, because you are there in every week. So what happens very early in the morning, 6:30, I get to the unit, then just get to any bed. Then the bed is prepared. I'm covered. Then that happens after taking my weight. So the data is taken for the weight, and then I'm made comfortable on the bed, and then the nurse technician or the nurses begin to hook you on a machine. And now this is the time when the patient also takes a proactive action and speak about his health, share with the nurse how he feels, how you feels, and then it is captured, whatever you say, so that as you continue treatment, they can do some adjustment based on things, on vitals. Sometimes high pressure, especially like myself, I suffer low blood pressure intradialysis, simply because the doctor says that having my central vein stenosis makes it possible, a possibility of that one happening. So the nurse basically check on us time and again until 4 hours ends. However, we've got some challenges, as you know, but then the most crucial part of it is that as the treatment continue, you request your nurse or care team to adjust your treatment based on need at that particular time. For example, you may need to have a target of maybe 3 liters, but then because of low pressures makes you not achieve that 3 liters. So yes, it all depends. Sometimes treatment goes fine, sometimes it doesn't go fine, especially the patients also who has other morbid factors like cancer and the rest. And sometimes their treatment becomes complicated throughout. Yes, this is basically how it looks like, until your treatment ends. After that, we are provided with some lunch. I know it doesn't happen in US.
Wait a minute. You said y'all provided with lunch?
Yeah, we are provided with lunch
Because
at
they
the facility where,
lunch. At least the clinics that I worked at, outpatient, they don't provide lunch for kidney patients. Now, I can't speak out in California, the units that are in Beverly Hills, because them people in Beverly Hills, California, got money. I'm talking about money where they pay out of their pocket type of money for their treatment. And their money, what I heard from a technician that worked in one of these clinics out in Beverly Hills, California, where people have money, that they control a unit. They control a unit because they pay in cash.
Cash, okay.
But share that they provide lunch. What do they provide for?
Yeah. At least they provide a bite. They must have noticed that many people really
Brother Moses
miss enough that they come and.
I'm sorry. Let me interrupt. We got Tabitha back.
No worries. Okay.
Thank you.
All right. Welcome, Tabitha. Is everything
okay?
Hey, I'm back. Thank
Can you hear us?
I think my wife. Yeah.
Thank you.
The internet. I can hear you.
Great.
Awesome.
So let's try to finish up with some of our questions we had. The one question I had, what are the most common reasons patients come for dialysis in Nairobi? What are the most common reasons why you see patients coming for dialysis?
Okay, like if the kidney has failed, they will come. We have patients who have hypertensions, who have diabetes. Patient can also get malaria, and the kidney can fail. If someone has diarrhea and vomiting, the kidney can also fail, and they can start dialysis. A patient can also do abortion, and as a result, because of sepsis, the kidney can fail and they can start dialysis. However, a patient can also be on dialysis and come like an emergency for dialysis, and some of our emergencies are what we call pulmonary edema, when a patient is having a lot of fluid in the body and some of them are not even able to sleep, they're not able to breathe, and we take it like an emergency. That is a regular dialysis patient. A patient can also have what we call hyperkalemia, high potassium, and when they come in, they need like an emergency dialysis. Yeah.
Oh, thank you so much, Tabitha, for that. Let me ask you, Tabitha, and then I'll let Brother Moses ask you some questions. Tabitha, how do you prepare a patient who's new to dialysis, medically and emotionally? Like if someone's new starting dialysis, how do you prepare them?
So this is how I prepare them. They will be sent by the doctor with the results. That is the results for urea and creatinine, and maybe if there is any other results that need to accompany that. And I will allow the patient to understand what does it mean. What does high urea mean? What is the normal urea? What is the normal creatinine? Now your creatinine is 800 and the normal for us is up to around 130, and then I help the patient understand what does it mean to have your creatinine at 800. It means that this is in a simple language, I tell them this is like poison, and when this poison is so much in the body, this is what happens. A patient is likely to vomit, is likely to have diarrhea and vomiting, is likely to scratch themselves, is likely to feel like a lot of fatigue, and we need to remove this urea and creatinine to make them to be a little bit lower. So after we've understood what it means to what it really means to have high urea and high creatinine, I tell them the doctor has recommended you need dialysis. Then I tell them what is dialysis. Is trying to remove this urea and creatinine and excess fluid from the body using artificial way, where we are going to use the machine. And this is what we usually do. We put a catheter. If it is an emergency, we are going to use a catheter, and this is where we put the catheter. And sometimes I show them up here. This is where you're going to put the catheter. It's either subclavian or maybe the jugular. I also tell them we have what we call the femoral down there at the leg, and when we are putting the catheter, I tell them you will just feel a little bit of pain when the doctor is inserting, is trying to inject the lignocaine. But after he's injected the lignocaine, you will feel like the doctor is doing something, but you will not feel the pain when the catheter is being put. And then this catheter that is up here, it will go up to the heart, and we need to take care of this catheter. This catheter is not supposed to be used anywhere else apart from the dialysis unit. The catheter is supposed to stay with a bandage. And this catheter, in case you wake up one day and you find it has fallen, please don't try to return it back, because you'll be putting a lot of infection inside your body. This catheter will not make you not to sleep. You can sleep very comfortably. You can continue with your work. There is no problem. For very young people who maybe cosmetically, they are like, how will I look like? So I'm like, you can just get something where you need to, it doesn't have to be shown outside there, but with time, you'll just feel comfortable and you can just walk and go do your work. Then I tell the patient that we start dialysis 3 sessions, the first session today, tomorrow, the 4th day. Then we continue with 2 sessions per week. The reason we are doing 2 sessions per week is because our insurance fund does not pay the 3rd session. So what we do, we recommend them do 2 sessions per week, which is very, very important. For Monday client, they come on Thursday, Tuesday, they come on Friday. On Wednesday client, they come on Saturday. And they just continue with that dialysis very well. Yes. So wow. I prepare them like that.
Wow.
Yes.
I'm sure that's a lot. Brother Moses, any questions you have for Nurse Tabitha?
Absolutely, I have. Thank you so much, Tabitha. You've really explained it, and your words really caps it all. We are glad we are sharing this story with you. Sister Tabitha, let me ask as a patient, just this one simple question. Can you share a memorable patient story that taught you something important about the care and compassion throughout your work?
Yeah, so many patients. There's one patient who came with he had come just for regular dialysis, and he said he's not feeling well. And when he said he's not feeling well, we had already allocated the machine. But now we had to negotiate with the one we had allocated to kindly assist us. We get back the machine so that we can dialyze the one who is not feeling well. But just as we were preparing the machine, this patient collapsed and died. And for a moment, I felt like I want to run away. I felt like I have made a mistake. In fact, I went to hide. And one of my teammates came and found me, and he told me that you did not make any mistake. But I was hiding after we had already done the resuscitation and we had lost the patient. And he told me, you did not do any mistake. In fact, you did the right thing. You allocated the machine. You were able to assess your priority. That's the time that I was assisting when I was doing dialysis. And what I want to bring out is that even the caregiver go through that pain of losing a patient. It's not just a patient. This is a human being. Yeah. This is just one story. Of course, we have so many other, like when a patient has been transplanted, after some time, we've gotten pregnant. You have done it through with them towards this pregnancy, following them even to labor ward to find out, do they still have their medication? Remember, even if you're going for surgery, you have to take in your transplant medication. Then you hear they've already gotten a baby. We have so many success stories in the renal unit. I have one patient who dialyzed for a very long time. That is a patient dialyzed for 25 years. I found her on dialysis. By the time she died, her daughter, who initially was like 3 years, had already started working. And the reason why this lady died is not because she failed to come for dialysis. No, it is because she just went for surgery and complicated, just like any other person who can go for surgery and complicate. And to me, 25 years was just a real success. And I keep repeating that story to so many people, because she lived and she was a teacher. If she could not go and teach, she would come and tell you that she would tell the other teachers, help me to teach, I will mark the books. And that is success. Yeah, that is a real success. Yeah.
Thank you for sharing that. I can resonate with you about your story that the patient collapsed, because I had that happen to me early in the morning, very early in the morning, when patients started the treatment and the person was at the scale, and once they weighed, they far as passed out or went unconscious at the scale, and we started CPR. And unfortunately, we lost that patient. And I know you said that you kind of went away from the scene afterwards, probably to gather your thoughts and to go through what you went through. And I also do the same thing. Well, at that particular time where I was at, there was a hospital across the street. So anytime that I participated in a code or had to do CPR, after that event, I would go to the hospital, to the chapel, and I would pray, because that takes a lot out of a person doing CPR, and you want to make sure that your patient makes it through that event. So I can definitely relate to what you're saying when it comes to you having to perform CPR or go through that event and then remove yourself from that area to kind of recollect or gather your thoughts. So thank you for sharing that. Brother Moses, any other questions you have for Nurse Tabitha?
Oh, yes. Let me just comment on Tabitha's story. We've seen many of, especially the female nurses here in Kenya, they become so much emotional to the extent that they even fear sharing such stories. Maybe you ask about someone that you used to see him on dialysis, but now you've come 2 sessions, you haven't seen him or her. Then you ask, where's this guy? Then few will have the courage speak it up like Tabitha. Thank you so much. But then, how do families tend to participate in this care? Maybe talk about it in your own context. How do families tend to participate in care?
So for families, when you're doing counseling in the first place, when a patient is just has just come in and now want to start dialysis, we involve the family. If someone had come with the family, we will involve the family. If we have not met the family when they are starting dialysis, along the way, when they come to the clinic, we insist, let them come. We counsel them so that they can learn how to participate in bringing the patient for dialysis, in buying the medication. The patient has got huge prescription and they need to spend some finances. The patient needs to go back to work. And all this, we need the family to come in and participate. And if they don't know their role, they will think that the patient is very strong, or maybe the patient is too weak, cannot be given any responsibility. At the same time, we are talking to the patient. As soon as you are strong, can you just go back to work? Whatever you are doing, try, negotiate with your boss. You may not be able to leave something that is up there, but there's something you can do in the office. Maybe you can organize the papers there. Maybe you can, there's something you can do at work. So don't completely just resign from work. You need your salary, your children need to grow up. There's a lot of responsibility on you. And even if it's a young person, if you're in school, continue with school. If you are working, continue working. And we involve the family so that they can support them. If it's someone who is married, we tell them, even if it's about sexuality, they can just continue. And for patients who are on dialysis, I tell them, like, if you're able to control your blood pressure very well, if you do not have infection, if your HB is okay, you're able to dialyze and dialyze very well twice a week, even your sexuality kind of is able to just come back to normal, even if it's not completely normal. Sometimes you can just time. There are those people, after dialysis, they're very strong and they're able to perform very well. There are those patients, maybe the following day, they will be able to perform better. So I tell, when I bring the couple in and I tell them, you can time this way and you'll see it is working. You don't have to completely abstain, because I met some patients who are saying, I told my partner this year I should not, we should not even try to have sex. But the reason he's doing this is because there are times he was trying and it was not possible. So what I do, I talk to them and I tell them they can continue with their normal life. I remember there's one patient who said that he went home and he found the husband had already brought a different bed. So I told her, go back to your bed. Just go back to your marital bed. Life is doable. You can continue with life. And with this, you can see the families are able now they're able to support each other. They're able to continue very well. Thank you.
Awesome. Thank you so much, Tabitha. You've just capped it all. Thank you so much. Yeah.
Thank you.
Yeah. So just let me add just one
Brother
more
Moses,
question.
I'm
Yes,
sorry to
Brother Steve.
interrupt. I'm sorry to interrupt. We just got a question from the audience that I just want to ask Ms. Tabitha to answer. P Teach 9957 asks, are there any protocols or assessment a patient go through before their treatment starts when they come into the dialysis clinics? So do the nurses, before the patients get on dialysis, do you listen? Do you do any assessments, like listen to lung sounds, heart sounds, check for edema? Can you describe that for us, please?
Yes, there is some protocol. Okay, when the patient comes for dialysis, you have to do a blood pressure check. You have to check on the latest UEC, that is urea creatinine, how they are. You also have to check on the latest HB. At the same time, you also need to assess. You can check on the pala. They can also remove their tongue to see how they are. Again, you also need to auscultate and feel, can you feel maybe there is fluid in the body? Again, also when you are assessing, is there edema on the eyes? Is there edema even in the legs when you touch them? Is there pitting edema? Again, when you look at the previous weight and the weight today, what is the difference? Does it go hand in hand? Because sometimes maybe somebody has added weight and not just fluid. Again, is the patient able to pass urine? If the patient is not able to pass urine, how much is the patient taking? And then again, you also need to take on the temperature. Is the patient having a fever or not? And then again, when you are dressing the catheter, is there any discharge? Is it clean? Is the catheter working well? How are the flows? All that really you need to consider that as you are putting the patient on the machine. Again, there are patients who, when they are put on the machine, their blood pressure goes up. There are those patients who, when they are put on the machine, their blood pressure goes down. It's good to know which kind of which kind of a patient are you dealing with. For those whose pressure go up, we advise them, when you're coming in the morning, take your blood pressure medication. But for those whose blood pressure goes down, we just tell them, kindly do not take your blood pressure. For those who are diabetic, we tell them, kindly do not take your insulin, because your blood sugar is likely to drop completely. At the same time, for those who are diabetic, you can even tell them to have 1 or 2 sweets every hour. They can just take a sweet so that their sugars may not completely drop. Yeah.
Awesome.
Thank you.
I'm sorry. Thank you so much for that explanation, Tabitha. Brother Moses, back to you.
Oh, well, thank you so much. Let me just add, Tabitha, allow me to add again one more question. What are the misconceptions patient or the public has about dialysis?
There are those who say once you start dialysis, you will never stop. And we also have very nice success stories, especially for acute kidney injury. When you manage the acute kidney injury very well, the patient is able to recover and even stop dialysis. And we also advise them to make sure they are followed up yearly, because that kidney, because it has been injured, it can also get to chronic. There are people also who think it is witchcraft. So what will happen? Just to give a short story, there's a patient I told that he needed dialysis because the creatinines were 800. Then he disappeared and came back when the creatinine were very, very high, and he was actually in uremic encephalopathy. So he had gone to seek opinion. So some of the misconception, people think that you've been bewitched. There are those who also think that if you go and do herbal medication, it is going to work, and it's not going to work. Yeah, those are few misconceptions. Yeah.
Wow. Thank you so much. I know there are many. We can't exhaust them today. There are so many.
Yeah.
And then let me add another one, Tabitha.
Yeah.
Yeah. What are the biggest barriers to accessing dialysis care in Nairobi? And maybe you can talk about cost, machine, staffing, transport. I mean, you can talk about something of that nature.
We have, of course, the distance. We thank God that the machines have been supplied in many areas, but there are still patients who have to pay a lot to access the dialysis. Meaning, if you are living in the interior, you cannot. There's one of the county called Moranga. Of course, that is where I come from. We have mobile dialysis, and they go around doing dialysis. If such a thing would happen to so many other places, it would mean heaven. Again, finances, right now, economically, like in Kenya, we are very, very much down. And it means if you're not able to pay for your insurance fund, you cannot access dialysis, which is very, very, very sad, because now, like, dialysis is just like another basic need for a dialysis patient. And of course, the shortage of staff and the shortage of the machines in many areas. Thank you.
Wow. Thank you so much.
Yeah.
Brother Moses, let me ask this question right quick. Because what you just said about the shortage leads me into my next question. What training and support do nurses in dialysis need the most in Kenya?
We already have several hospital training nephrology nurses. We have several of them who are training the nephrology nurses, several of them, which is very good. When it comes to things like transplant, it's an area where we have very few who have trained in transplant nursing. Just a very small percentage of the nurses have trained in transplant. But for dialysis, they're very good, very, very good, and it's detailed. And nowadays they are doing a 2-year course, as we did a 1-year compact and compressed course for a whole 1 year. And also we have it up to master's level, higher diploma, and then from there, if you've done a basic degree in nursing, you can do masters in nephrology. Most of our universities, several of them are offering the nephrology nursing. Yeah.
Wow. Okay. So nurses do you think nurses need more training when it comes to working with patients with kidney failure?
Yeah, they still need more training, more advanced training, so that they can handle their patients even much more better. Any training really means a lot, because like you become a specialist in that area. You see, like now the way I do counseling, in my department, I'm one. Yet we have so many patients on dialysis, so many patients for transplant. We have the caregiver, we have the community, and I think many other hospitals, most of them, they don't have a nephrology trained counselor for this. It's also like a very big gap, because a normal counselor, if a patient comes and has not slept, you'll think in terms of, are you stressed? But for a renal counselor, if a patient has not slept, maybe the ureas are high, or maybe the patient has a lot of fluid, and that's why he was not able now to sleep. And you will recommend the patient to go for dialysis. Maybe the patient does not even need so much counseling, and the counseling maybe he needs is just to reduce maybe the fluid he's taking. So it's still also a very big gap for most of our patients, because if there are many, they'll be able now to support the patient very well. And there,
Wow.
our patients keep changing.
Yeah,
And
I'm sure.
mm,
Brother
yeah.
Moses, let me get in one more question, then I'll let you ask. Nurse Tabitha, my biggest concern is what helps you cope with the emotional strain of your job? What helps you cope with the emotional strain of your job? Is it peer support? Is it your faith, supervision? What helps you cope with your job?
So first of all, I believe in God. I pray. Yes, we also do debriefing in the hospital. For all our nurse counselors, we have a debriefing session that is like almost like once a month. I also have a friend who has been a very close friend of mine for a long time, and when we are on the same team, she will call me and ask me, "Have you taken a cup of tea?" And that one also helped me to really cope. At the same time, I love a lot of fun and outdoors activity, and kind of they really help me to, it's like a way of debriefing. I will swim, I will dance, and again also quality time with my family also really help me to cope with what I've been going through, maybe through the day. Yeah, listening to music, reading my Bible, all that. Yeah,
Wow. Back to
it
you, brother.
helps.
Thank you so much, Tabitha.
Yes.
Let me inject just one more question. Are there low cost or community driven initiative in Nairobi that improves kidney care or early detection?
The low cost initiatives. Okay, we have several, like we have Renal Patient Society of Kenya, where most of our kidney patients usually come together and they air out their views. Again, also, whenever we have like the World Kidney Day, many of the media station invite people to talk. I think I've given several talks on the radio and even on the TV, just like community sensitization. At the same time, we do screening for early detection. And when you're doing this screening, we check on the blood pressure, we check on the urine, where we'll do urinalysis, where we are checking on blood in urine, sugar in urine, or maybe if there is kind of any infection. At the same time, we do a BMI, where they'll do the height and weight, and then they will calculate to see if you are overweight. The reason behind doing this is because if your sugars are high, you're likely to be moving towards diabetes. If your blood pressure is high, you could be hypertensive. And these are the reasons that really can contribute to to kidney failure maybe later in future. At the same time, in the urine, if there is protein in urine, or if there is any sugar in urine, it means there is a problem. Why has the kidney allowed the protein to come out? And maybe you just need investigation. And any moment there is free screening, kindly run, get screened. You might really save yourself from getting into chronic kidney failure, where we say that maybe your kidney is not reversing, and now we are just moving towards dialysis. It really makes a difference. Yes.
Okay.
Thank you.
Okay. Just on the same question, let me just sort for some clarity. Do patients also involved maybe in the planning of these community-driven initiatives, like from the start to planning to entirely the event? Do they include patients?
In
or
dialysis?
It's just left for the planners of such organizations? Do they include patients in those community-driven?
In those community-driven, ideally, the patient is supposed to be included. To be included when these things are being planned. That is what is ideally that is supposed to happen. But I'm not very sure if most of them are included in those initiatives.
Okay.
Yeah.
Thank you so much. Back to you, Brother Steve.
All right, thanks, Nurse Tabitha, for answering those questions. We're kind of coming down to our time, but I just had several more questions that I wanted to ask that I feel that's important for our brothers and sisters across East Africa, especially in Kenya, that may be going through kidney failure or newly diagnosed. What are your top three? I wanted to ask you for three, but what are your top three practical tips for someone starting dialysis in East Africa? What are your top three practical tips for someone starting dialysis in East Africa?
Okay, top three tips. First of all, see your doctor and follow the instruction. See your counselor, follow the instruction of your counselor, and look for him for the counselor anytime you need emotional support. Follow your nutritionist, because there are some things you need either to avoid or to include in your diet. Very, very important. Then kindly, you can do life even if you are on dialysis. Life must continue. So the doctor is important, the counselor, the nutritionist, and your dialysis schedule. Kindly, if you've been told 2 times a week, do the 2 times a week. If it is 3 times, kindly do the 3 times a week. Okay, and life will continue.
Great. Now for caregivers, because we know there's a lot of caregivers out there with someone that they're supporting, with someone with kidney failure. For caregivers, what should they know, and how can they best support a loved one on dialysis?
A loved one who is on dialysis require a special diet, So kindly, as a caregiver, be available to guide, to help the patient. Make sure your patients attend dialysis twice a week. As soon as they are able to go back to work, support them to go back to work. At the same time, as you give out the care to your patient, do not forget yourself. Remember, you are very, very important. As you are supporting your patient, you also need to eat. Your work also need to continue, because if a patient start dialysis and they do not stop, does it mean for like over 25 years, you'll always avail yourself for dialysis for this patient? It means you also need to bring other people on board, so that you, as the immediate caregiver, you need to continue with your work. So remember, your life also doesn't have to stop as you are providing care. You are important. You also need to look for a way to do self-care for yourself as the caregiver. It is very important.
Mm-hmm.
Yeah.
Thank you for that, Tabitha. And I have a couple of questions from the audience
Yeah.
that I want to ask you. One is, how is the renal diet or plant-based diet promoted in Kenya? How is the renal diet or plant-based diet promoted?
Mm-hmm. Okay, for the renal diet, we have our nutritionist, who maybe with time we might bring her on board, so that she can give out the details of what she is able to recommend to the patient. Because many times I tell them, if I give you this direction, I might mislead you, but she is much better and very good when it comes to giving details on renal diet. Yeah.
Okay. And
Yeah.
let me ask you this. How can listeners who's watching this right now and who's going to be watching the broadcast afterwards, how can they, families and healthcare workers, get involved or support better kidney care in East Africa?
The healthcare worker, they need to support the patient while on dialysis. Of course, when you're assessing the need of the patient from head to toe, and advise rightly, refer on time, because as a patient is dialyzing, he could be having other comorbidities, or he could be having other issues that need attention. Involve the practitioner who is supposed to support the patient. Again, involve the family, and if the family is not so much involved, involve the counselor, so that the counselor and the social worker can bring in the family to support the patient. It is a journey. It is a journey for the healthcare worker. It's a journey for the patient. It's a journey for even the caregiver, and we all need to work together in harmony for the well-being of the patient. So they need to work together and work together, advise well, and wherever you need to refer, just refer. Yes. And again, we are saying, even as the healthcare worker, do not burn out, because dialysis can be draining even for the healthcare worker. So take care of yourself also.
Brother Moses had mentioned that in order to get a consultation with a dietitian or social worker, one has to pay out of their pocket. Is that correct?
Yes, they pay.
So
they're supposed to pay. Yes.
How would one, if they're in a position where they can't afford to pay to seek consultation for nutritional assessment or any type of mental health discussion with the social worker, how are they able to cope with what kidney failure may present to them, far as nutritional wise and mental health wise?
So for those maybe who are not able to raise the amounts, we have the social worker, and the social worker is supposed to assess their socio-economic status, and is supposed to recommend for the waiving of the bills. And our hospital has that clause where they can be assisted. Yes,
Okay.
they can be assisted. Yes, the
Brother
bills can
Moses.
be waived.
Okay. Oh, okay. Okay. Brother Moses, any last questions you have?
Um, uh, Let me just add the last question on the last point. How do this really this waiver takes place? Maybe do patient told now your voucher is free, you can walk home, or maybe just take us through so that because there are several patients who are in need of such services, and because you mentioned they are there, we can always refer them, maybe share your contact so that you can assist them in one way or the other. I know there are so many of them out there who are really needy, who, if that is the case, they can get help from Kenyatta National Hospital.
So, like there are patients who may come also if they need a dialysis and maybe they've not even paid for the hospital insurance fund, something like that, and they also need urgent dialysis. So they are sent to social worker. The social worker assesses their socio-economic status, and then he's able to write a report, and then the doctor on duty is supposed to sign, and then after the recommendation for the waiver is done, the billing is done to show that the bill has been waived, and then they go with that. It's like a receipt to show it's like you have paid, but now the bills have been waived. And then whichever services you are supposed to get, it's written there, the amount, and then you take back to the person who had sent you to seek the services. And then if it is whatever service you needed to be rendered, they are rendered. Yeah. But we also have, there is that particular office. Yes. Even in casualty it is there. And many other departments.
Okay.
Yeah.
Brother Moses, are you still there? I think Moses froze up his internet. We know how sometimes the internet in Kenya is unstable. So my last question to you, Nurse Tabitha, before we close our show, is oh, okay, you're back, Brother Moses. You had froze up. You had froze up, Brother Moses.
Yeah.
So I'm asking Tabitha before before we close the show, I just want to get one comment from Nurse Tabitha, and that is there anything, Nurse Tabitha, you want to say directly to patients currently on dialysis in Nairobi or across East Africa before we end our broadcast? Is there anything you want to say directly to patients on dialysis in Nairobi or across East Africa that may see this show?
Thank you so much. I would say that Steve the kidney nurse is doing a very good job of educating patients. You can log in and see the YouTube information that is actually been sharing. They are very, very much educative. And I would like to tell you, you can follow him together with Moses Kidney, who is a kidney advocate, and also a patient who is on dialysis. Telling you that if you are seeking the counseling services as a dialysis patient, I'm available for you. You can you can call me directly. Maybe I'll later share my number. I'm ready to support you and to journey with you. If the doctor has recommended that you need transplant, come, I'll tell you whom you need to bring. Like where I work, we also do kidney transplant, and I will tell you who you are supposed to bring for transplantation. I'll tell you about the transplant process. And if you've been transplanted, you are out there, you don't have anywhere to go for the clinic post kidney transplant, kindly find a local program where you need to enroll. We usually recommend kindly be followed up by a nephrologist or come to the clinic. Where I work, there is a follow-up clinic for post-kidney transplant. And if you've been transplanted, kindly take your medication religiously as the doctor has prescribed. When you've been transplanted, remember that over-the-counter medication is a no, and it's a no. For any kidney patient, we say kindly do not take herbal medication. Follow if you're on dialysis, follow the 2 sessions per week as recommended by the doctor. Follow your drugs, follow the diet that has been recommended, and let life continue as near normal as possible. If you're strong enough to go back to work, kindly go back to work and negotiate with your boss. Whatever you can do, kindly do it. Otherwise, I'm very grateful to be with you in this show. Thank you so much.
Thank you, Nurse Tabitha, for coming on. We really appreciate you sharing your knowledge, your experience in your life, working with people on dialysis. Brother Moses, any last parting words that you may have for Nurse Tabitha before we close the show?
Oh, yes. First of all, let me thank Nurse Tabitha for really sparing your time. I know this time is a family time, maybe to bond with your family, but you saw this opportunity to save life and to impact knowledge as well to patients and even those who are at a risk of kidney disease. And then lastly, maybe if you are free, you can drop your number so that maybe warriors here in Kenya can maybe come over for counseling. Maybe you can take them through, and also you can let them know how much you charge or what you pay or what are the arrangements so that they can also benefit from that. We want to impact. Our vision is also to impact everyone positively, and not only by resource but knowledge-wise, and where possible, any kind of help can come from. So maybe to warriors watching out there, please contact Tabitha. She's gonna share her number, and then you can reach out to her. Thank you so much.
Yes, and I was just thinking here, Nurse Tabitha, before we leave, I would like to, if your time is available, maybe on some Sundays, you could come on the show and we could have a segment specifically dedicated to you something like Tips with Nurse Tabitha or whatever, where you could come on and share knowledge, wisdom, education, and information to kidney warriors, and not only in Kenya, but East Africa and abroad as well. If you would like, for that, and if you have the time to, it doesn't have to be every Sunday, but maybe every other Sunday you could come on and just share some words of wisdom, and like I said, have a segment where you can share tips, inspiration, information, education for patients that are already undergoing kidney dialysis, or just about to start, or maybe in the transplant situation. So we would love to bring you back for that.
Thank you. It's my pleasure. I'll be happy to share this knowledge with many patient caregivers and to the community. It's my pleasure. Thank you so much, Steve, for providing this platform. Thank you so much, Moses, for connecting. Thank you.
Yeah. Thank you for taking the time to come on, and we'll see you soon. And again, have a great evening with your family. And again, thank you so much. It's a pleasure meeting you and a pleasure having you on as a guest, and definitely look forward to working with you and sharing your knowledge and experience to kidney warriors, not only in Kenya, but in East Africa and abroad as well. So again, thank you, Nurse Tabitha, for coming on, and we'll see you soon, okay?
Thank you so much.
Thank
we are
you.
so
Thank
glad.
you.
We are so glad.
All right, we're going to drop you down,
Thank you.
and we'll see you soon, okay?
Yes.
All
Yes.
right. Take care.
Take care.
Thank you.
Right.
God bless you.
God bless you as well, Tabitha. Hey, Brother Moses, that was a great interview with Nurse Tabitha. What was your thoughts?
It was great. It was great. And at least we've changed the image of the broadcast, and we hope to do this further, and to many will extend to expertise on different areas. Of course, I was also having in mind we get a nephrologist doctor, and then a nutritionist. Then as we escalate it that way until we will believe it, we'll be talking here with even head of parastatals. So it's gonna be big. From my imagination, it's gonna be big.
Yeah, I'm looking forward to that.
Yeah.
Yeah. Okay. Sounds good. Definitely looking forward. Please keep in touch with Tabitha, because I want to have her on maybe every other Sunday. Not every Sunday. I don't want to take up her time like that, but maybe every other Sunday, or maybe twice a month, whichever she prefers, and giving us tips, education, wisdom, knowledge, and information pertaining to kidney disease and dialysis from a nurse perspective in Kenya or East Africa. So great show. Always good to see you, Brother Moses, and look forward to seeing you next week. And I definitely pray that you have a safe and secure treatment coming up on Tuesday, correct?
Yeah, Tuesday.
Yeah, Tuesday and Friday. So do you have any last words before we end the broadcast?
Well done. We just expect much more better. To our viewers, we are so great at this moment. You've walked that journey with us, and we'll continue providing the best. Back to you, Brother Steve.
All right, Brother Moses. Definitely appreciate that. To everyone else, thank you so much for watching the show. You can watch the rebroadcast at Stevethekidneynurse YouTube channel, Facebook page, and also the FIGO, F-I-G-O, the FIGO Initiative Facebook page run by Brother Moses Kidney, also known as the Kidney Ambassador. So we thank you for tuning in this Sunday, and we look forward to seeing you next Sunday on another episode of Kidney Hub East Africa. And as we leave, we would like to share a PSA on kidney disease. We see you next Sunday. Brother Moses, take care. See you soon. Everyone else, thank you. God bless you, and have a great week. We see you next week. Goodbye.
God bless you too. Bye-bye.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.